Good to see you and everybody else that's joining our collaborative today to discuss the interprofessional aspects of deprescribing, which is sounds pretty straightforward, but as we'll find out, maybe not so much. So maybe if we can just go to the next slide and talk about the objectives. Well, first, yeah, I'm sorry, you can go back to the disclosures. So this, for Dr. Brandt, do you want to talk about your disclosures there, Nicole?
Sure, Don. And again, thank you for this opportunity. So I'm federally funded, like Dr. Jurovich, from HRSA with our Geriatric Workforce Enhancement Program. And we'll speak a little bit more about that and the opportunities it affords all of you. We also have some federal funding from the National Institutes on Aging regarding U.S. Deprescribing Research Network, as well as a work on antipsychotics. Recently, we're doing some work with PCORI on patient engagement on medication safety, and we've been doing some work with IMPACT and CMMI on medication therapy management. So I do serve as a consultant from some other work, especially because I'll be talking about age-friendly initiatives where we've been doing some of this work. So Dr. Jurovich, I'll turn it over to you.
Yeah, that's great. And I just want to mention to our audience today that Nicole and I are going to be doing some passing back and forth here. And hopefully as the hockey season is starting to rev up here in North Dakota, we'll get an appreciation for those handoffs. So in terms of my support and disclosures, very similarly, the University of North Dakota has a Geriatric Workforce Enhancement Program, affectionately known as the GWEP, and we have some sponsored research from some other federal enterprises. I serve as a consultant for National Institute on Aging. I help review some of their grants and research, and I also am a consultant geriatrician for Sanford Healthcare System down in Fargo. I say down because I live in Grand Forks here at the university area. So, okay, can we have the next slide, please? So our objectives today are to basically describe what we call the 4M's framework. And we want to talk about what matters in relationship to medication burden and management. So these 4M's are always interrelated with one another. And we'll be discussing those shortly, what each of those 4M's are. Maybe many of you have already been introduced to the concept of the 4M's. So I apologize for the redundancy, but there are some folks that are still getting introduced to the concept. And we want to identify at least two different approaches that have been attempted for interprofessional deprescribing in long-term care. And finally, we want to identify opportunities to improve communication and person-centered outcomes surrounding deprescribing. Next slide, please. So this really intrigues me, and I just wanted to share this because we're under somewhat of a challenge here in the Dakotas, both North and South Dakota. You know, our COVID positivity rate is approaching 7% on a 2-weekly basis. And the importance of that is that when the community positivity rate starts to increase, that means that the nursing home and long-term care facilities are going to be at increased risk, even though they're on essentially a lockdown. You know, right? They've got all these mitigating features. But what just really intrigued me was this data that here in Grand Forks County, which admittedly is a smaller population than Cook County, which is where Chicago is located. But I mean, for goodness gracious sakes, look, you got a much bigger population, a much more diverse population, and there's a 32% lower rate of COVID in a very, very large, millions of people community. And so I think we need to reflect on why that might be. This is not the purpose of this particular presentation, but I think this just really illustrates that if people put their minds to reducing COVID exposure, that you can get some impact there. Okay, next slide, please. Yeah, so we want to frame what the issue is and what the opportunities are. I added this little picture here of a former professor of mine from college who was an impressionistic abstract painter since deceased, but he had all these very colorful abstract paintings that always remind me of opportunities and the joy of collaborating. Next slide, and then I'm going to hand off to Nicole. So really the ultimate question we need to ask, are there too many medications per nursing home resident? I think at first blush, we would say, yeah, for sure, for those that are familiar with this, but not everybody's in agreement with that. And so hopefully by the end of this presentation, we can convince you that there are ways to reduce medication burden. And hopefully by doing so, we'll reduce the side effects. And I just have a quick story to share with you, is that there was a famous matriarch, the Bass family from Fort Worth, Texas. And one of my colleagues, who's a geriatrician down at University of North Texas, was doing a home visit on this near 100-year-old lady. And she was pretty much bedbound. And so the geriatrician friend of mine decided that it was time to get her off of all these medications. She had a list of over 12 medications that included opioids and psychoactive medications, sedatives, and so on and so forth. Anyways, she weaned the patient off of all these medications. The 98-year-old lady woke up and she says, and she's very wealthy, I mean, multimillionaire, and she goes, "Which of my darn kids put me on all these drugs to put me, to get their, their will, my will?" So she wrote them all out of the will because she figured that all of her children were trying to accelerate her early demise. So anyways, it's a good story. She woke up and became very functional for another 5 years. So it's a good indication, anecdotally, that by doing this, that we can improve function and the lifespan even. Okay, so Nicole, with that said, I'll hand off to you.
Awesome. Well, thank you, Don. And I just want to take a moment. Many of you guys and women watched the football game last night. I am based here in Baltimore, Maryland. So as we talk about fumbles, we capitalized on that fumble in the fourth quarter with just less than 2 minutes left. So really excited to beat Kansas City. Sorry if there's any Kansas City Chief fans there, but I had to capitalize, Don, on that reference to transitions and fumbling. So we may not be passing the puck or passing the football, but we will be passing slides. So we hope we don't fumble, but if we do, we hope it's advantageous to you all. So this is a wonderful opportunity. I've really just gotten to meet the team from North Dakota Geriatric Workforce Enhancement Programs, and with the Pharmacy Academy that's developing there under the leadership of Rick. So we're really excited to support a topic near and dear to my heart. As many of you may know me, or maybe who don't know me yet, I'm a practicing pharmacist, but as mentioned by Rick, I direct an aging center and really have dedicated my career to helping improve medication use and safety, because what we're talking about here is not just a number, but how it impacts that particular person, that older adult, and the caregivers associated with it. So thank you for talking about what matters, Don, and the relevance to that Texas story, because what matters to her is that quality of life and function at the end of her years. It sounds like she made it to 100, if I do my math correctly there. But we know that polypharmacy is rising, and maybe it's beneficial to our older adults. We know that we're using multiple medications to treat many chronic conditions, and that our older adults are disproportionately taking more and more prescription medications. But I think what becomes the interface for this conversation today is really what matters to our older adults. And are we potentially over-medicating or over-prescribing or inappropriately prescribing? And I ask this question as we've narrowed down into looking at transitions of care, not just transitions of this discussion, but when we look at, in particular, transitions from a hospital to a skilled nursing facility, where we're sensitized that many of you may be working, that there's an average of 14 medications. And we know when you enter a skilled nursing facility, every medication that is administered has to have a prescription associated with it, even though it might be an over-the-counter or an as-needed. So there's a lot of opportunity to reevaluate medications and to reduce not just the burden on the staff, but the burden on that family, the burden on that resident when they have to take that many medications. So I think there's a lot to be looked at in terms of optimizing medications. And that's really the goal of this talk today. I wanted to share with you when we look at data that we know that there's increasing rates of medication use despite the risk for medication adverse drug events, as Don alluded to, as well as frailty. There's been a lot of work looking at frailty, and the population that many of you care for in nursing homes may be very frail. Even though they're chronologically young, they may have comorbidities such as HIV or other disorders that make them more frail and at risk for adverse effects of medications. And what was disturbing to me, having cared for older adults with dementia and having loved ones afflicted by dementia, is the high utilization of medications sometimes in the last weeks of life, where difficulties with behaviors and difficulties with dysphagia may preclude them being able to take the medications safely. So I asked a colleague of mine who works in long-term care locally here to share some data with me, because this problem permeates beyond just skilled nursing facilities, but in assisted living facilities as well, in terms of the number of over-the-counter and prescription medications. And though I'm not very familiar with North Dakota, but I'm learning that the regulations in assisted living facilities here in Maryland do have a pharmacist working in those facilities, but just every 6 months. So hopefully pharmacists can be part of the champions to improve the medication quality of prescribing. But what we've seen in some of our own research is an increased use of psychotropic medications, both in nursing homes as well as assisted living facilities, especially during the pandemic, which Don talked a little bit about some of the changes and challenges that happen not just within a region, but in care settings. So this was a beautiful picture, but this beautiful picture doesn't depict what we think of when we think of prescription cascade or prescribing cascade. And as, again, a practicing pharmacist embedded within a primary care clinic, I know the more specialists we have, the more prescribers our older adults and families are seeing, the more challenging it is to quote unquote quarterback their care. And that can often lead to potentially inappropriate prescribing or over prescribing. And I'm not sure if any of you want to chime in, but I feel 2 times I'm saying, why do we need so many medications, including corrective insulin or sliding scale insulin, when we have a hemoglobin A1C of 5.7% in someone who is in the last 1 to 2 years of their life? So I think we need to be mindful of that, because we potentially could be impacting hospitalization, and the very medications we give could be causing them other symptoms. And we see this with sometimes medications we use for memory, like cholinesterase inhibitors, causing stomach issues. And we start prescribing then proton pump inhibitors. And before we know it, we have low vitamin D levels. And you see exactly where this is going. But through communication with your team members, as well as your patients, residents, and families, you can hopefully help to prevent some of these medication-related concerns and issues. Don, anything to add to this? Because I know as a prescriber, I'm sure you have another complementary perspective.
Yeah, thank you, Nicole. Just from a geriatrician's perspective, we've seen an uptick in the number of patients exiting the hospital with antipsychotics. Part of that, I think, is maybe due to COVID-induced delirium. And what we're seeing is that there's no game plan for de-escalating those antipsychotics once they're prescribed. So it's, and it's affecting metrics. So just as an example, the bounce back rate to the hospital is very, very high for those individuals on antipsychotics. And I think I kind of revel in what I want to say, pride with my geriatric faculty who demonstrated this past year during the first, well, actually it was the second, right, COVID spike, that when they were working in the hospital, that they paid close attention to those medication lists. And they had the lowest bounce back rate of patients that were much older than the general hospitalist service. They had reduced their recidivism rate by down to 6%, which the national average is closer to 13%. So I think when you address these medications in a team-wise fashion, it's so important for not only the patient's quality of life, but also for preventing side effects and really the hospital metrics. So I think it's so important for, and I guess I might add, is that the geriatricians also had a long-term care practice and worked with the long-term care pharmacist. So that was part of the partnership and contributed to the reduction in post-hospitalization medications. So that's the main point that I would make, Nicole.
Fantastic. Thanks, Don. Great points there. And hopefully we'll tag team this slide together. But as we said at the very beginning, and would love to hear if any of you are involved in the age-friendly health system movements, but I know there's work going on in North Dakota. So for those of you not familiar with the 4Ms, and you may have heard this before, so sorry if I repeat this, but the M that really is the key to the castle is what matters to the patients, which is really focused on that person-centered care and aligning care. And I think, again, speaking as a pharmacist on the team, it's really important that we communicate with our other team members as well as the family members to understand those care goals, because they're constantly changing. And that's really important because that really helps us to queue up sometimes their medication plans and treatment plans. And we all know that medications can negatively impact mentation and mobility, especially if there's some of the high-risk medications that could be increasing falls or delirium and function. So just a key work. And this work has really come out of the partnership between the John A. Hartford Foundation and the Institute for Healthcare Improvement, working with the American Hospital Association and the Catholic Health Association of the United States. And this movement started with 5 pioneer health systems and is now well on their way to, I think, over 2,000 health systems in about 5 years. So pretty dramatic and really focusing on the long-term care work. So Don, if you want to speak to a little bit of the work that's going on from an age-friendly perspective in North Dakota.
Yeah, absolutely. Thanks for that handoff. Just a lot of innovations that we're trying to implement with the age-friendly. So the age-friendly framework, it involves a persistent or consistent evaluation of these 4 different metrics, and then to create a management plan to implement those in response to those assessments. And I want to thank Rick, for coming up with the brilliant idea. He says, how can pharmacists become age-friendly certified? And so we tackled that question with the Institute for Healthcare Improvement, and they gave us some advice as to how to do this. And as a consequence of this collaboration, we are creating a brochure that we can hand to patients who do a self-assessment of these 4Ms. And so there will be the cognitive testing with the what we call the 88, which we might be able to cover it in a future meeting. But fundamentally, this self-assessment then allows an older adult to take the brochure to their primary care provider and say, can we discuss these 4Ms? The 4M rollout is basically if you're involved with a clinic, you can subscribe to the Institute for Healthcare Improvement and get enrolled as a potential age-friendly level 2 awardee. They currently are enrolling people here in September through the Institute for Healthcare Improvement. And I think Sarah from our GWEP, Dakota Geriatrics GWEP, put in the chat box the contact information if you want to learn more about this. So back to you, Nicole.
All right. Thank you, Don. Fantastic. So let's talk a little bit about the theme today, which is approaches to deprescribing. And we know that in today's healthcare, there's many barriers out there. But I think if we ground our recommendations and the work that we're doing in that patient-centered approach that we talked about with the 4Ms and age-friendly, we can really propel deprescribing efforts and really get at the best medication regimen and meeting our residents and patients where they're at. We'll share with you some tools that can be used within your deprescribing practice. And then we'll also be sharing some of our approaches during the pandemic and beyond from a quality improvement improvement perspective. So feel free to chat in any work that you might be doing in deprescribing. It's awesome to learn from your work. But let's start a little bit with the barriers. So fortunate, I've been able to mentor both pharmacy and medical residents. And one of the things we focused on in our practice was a QI project looking at proton pump inhibitors. And why we did that was to not only engage our learners, but to make us more aware of some of the fears and the concerns from the family and caregivers to stopping medications. And proton pump inhibitors, as many of you may be aware, are both available over the counter as well as prescribed. So what we learned is we might have thought we stopped them, but our patients and caregivers may have continued them because they were afraid they were going to have these reemergence of symptoms and they'd have to go back and see their specialist, their GI doctor. So I think sometimes a lack of awareness to what we do with those reemergence of symptoms and maybe other approaches that might be safer. There is also some concern regarding what happens when we stop these medications, and also coupled with the lack of knowledge about late life efficacy of medications. So non-pharmacologic approaches are really key. And then we need to be mindful that there is, especially with some of these medications, I know one of the classes our primary care practice asked us to look at was opioids, and there is dependency as well as addiction that we may be uncovering while we try to deprescribe medications. So I have to say we had our first outpatient detox with Suboxone in our practice, which I learned a lot about some of the effectiveness of the medication, but the inadequacies of our community to support some of the non-pharmacological interventions. So that's why this power of partnership is so key to understand those resources to really reach that goal, even though we may fumble at times. So Don, I'm sure you've had some successes and challenges in deprescribing. Do you want to share the prescriber perspective?
Well, yes. I can tell you what the pandemic is doing specifically from the prescribers is that a lot of the primary care doctors are being shuffled around like crazy. They're being redeployed to the hospital. And as a consequence, patients aren't seeing their usual primary care providers. It's also turnaround, right? So we've had about a quarter of our primary care providers move on to other positions, leave the area, and so forth. And so there's somewhat of a migration of primary care providers. And so that lack of continuity is really causing an impact on, and that is a barrier to deprescribing because, you're just trying to figure out who the patient is, let alone am I going to start taking away medications from them. And then, as Nicole was mentioning, you get people who are going like, oh my gosh, my psychiatrist prescribed that. And is that okay? And as a primary care provider, I try to empower, primary care providers for deprescribing. You use your consultants as consultants, but I think there's a little bit of a fear, and that this is a barrier, that primary care physicians are reluctant to change anything related to consultants. My favorite is the arguments I always get into with the cardiologist when I deprescribe amiodarone, which I think is one of the more evil cardiology medicines known to mankind. But those are some examples, Nicole, of the conundrum that we're having in primary care right now that actually is escalated because of the pandemic.
Don, thank you for sharing that, because I think what you hit on was this lack of continuity and shortage of providers. And I know I was a consultant pharmacist for a very long time in a facility, and I felt like I was the only consistent presence as we went through 3 medical groups, 5 directors of nursing, and being that advocate because you may know those residents the best. So I think it's important to convey that information so our patients and their families have an advocate for them as well, because continuity of care is huge. And pharmacists are in a wonderful position working with the team to really focus on some of those potentially inappropriate medications. I know some of you have sophisticated software, or you may be very in tune to some of these high-risk medications, such as medications on the American Geriatric Society Beers list. And these medications, we've talked a little bit, and we'll further talk about antipsychotics, but these can be benzodiazepines, anticholinergics, sedative hypnotics that also become under regulatory scrutiny as well. And so I think what we need to be mindful of is how do we ground that in resident person-centered care to discontinue those medications, especially if they are more confused or they're having issues with constipation, to really discontinue those medications, not just to mention that it's on the Beers criteria. And then I think to have a concerted plan to initiate that medication withdrawal. And I think, again, some of the medications may have explicit ways in which we can stop them, and others we may be very cautious in cutting back those medications over time and supporting the nursing team as well as the documentation. So I think it's really important as we look at this process that it's an iterative process. There's going to be times when it works really well. There'll be other times when we struggle. So Don, anything to add to that in terms of the process?
Well, I had a very interesting tweet from Dr. Kevin Kovinsky, who's a fairly well-known name, geriatrician from University of California, San Francisco. And he tweeted simply, he says, "When's the last time in your practice you thought about deprescribing for symptoms?" And so I think just the mindset of primary care providers, or, and consultants too, is that they don't always think firstly that those symptoms, the GI complaints or the fatigue, are actually due to one or combinations of medications that we prescribe. So I think it's a mindset, and we just need to enhance our thinking in primary care that, once somebody gets more than 6 medications, we better start thinking about adverse events and side effects.
Absolutely.
Thanks, Nicole.
No, it reminds me of Dr. Gerwitz, who's our East Coast constituency. Any new symptom should be considered a drug side effect until proven otherwise. I was actually told it was actually Dr. Gerwitz's wife who said that, but I'm not going to be the one to toss that in there, but that was something that was brought to my attention. So Jerry is just an amazing researcher, and he's been such an advocate for older adults and med safety. So some of us like mnemonics in our practice. This is another mnemonic that was recently published looking at polypharmacy, inappropriate prescribing, and deprescribing in older adults. And it really had a lens on both sex and gender, and some of the perspectives there in terms of goals of care, certain medications. And we've learned through the years that certain ethnicities as well as other groups may be more at risk for certain medications. So I know there's a growing sophistication with pharmacogenomics too. And I think we need to use these tools and frameworks such as the deprescribing.org has wonderful resources on their website. And then really focusing on that functional aspect of our patients with that geriatric medicine approach. So it's just a great synergy between geriatricians and pharmacists. And then of course, stopping those inappropriate medications. And really we get down to when Rick and Sarah asked us to do this presentation is, what can you take home tomorrow? I know it's already Monday, but I think what I've seen with success with the age-friendly health system movement is really identifying champions and a team. And I think during this pandemic, it's truly been through the teams I've worked with that get me giving energy to do what I do, because there's going to be good days and there's going to be bad days, but you're going to need a champion on certain thematic work. And whether you look at your own medications within your healthcare system or your healthcare setting that you want to focus on, or you use other tools such as the Beers criteria, stop-start criteria, and we reference and we will share the slides, as Sarah noted, with all these tools embedded within it that you can use. And I think it's really important to look at some of the existing workflow tools, such as EHR-based tools. And actually, one of the things we were looking at recently, Don, and would love to hear from others, is a tool called Cancel RX, which is a tool that you can activate within your EHR-based system to help discontinue medications. Because I have to go back to that amiodarone. I love how you said it was an evil medication. Well, I got to tell you, Don, we got a patient off of amiodarone, was so excited, did the happy dance. Took us a little bit to convince the cardiology team and such. They went to another health system who had an old list. And guess what? back on amiodarone. So it gets back at that communication and making sure our systems truly communicate, because we were back at square one again with deprescribing the medication. So Don, any thoughts about your lens of looking at implementing med-op programs through your work?
Well, I think definitely we're in a patient-centered medical home at Sanford Healthcare. And so that really is a conduit for team-based care. We also are blessed, as I think your program is, with trainees. And so once you alert the trainees into opportunities for deprescribing, then they get on on track and are able to do so. And I have to admit that it's always a little bit of a plus minus situation with deprescribing. I did have one kickback in terms of deprescribing a PPI, and the individual wound up developing erosive bleeding gastritis. But there was nothing in the chart to suggest that they really needed to be on, there was no high gastrin levels. All the checklists were in favor of deprescribing, but sometimes I think we need to also educate the patients about things to watch out for in that process of deprescribing, just to elevate patient safety as part of our component here for the deprescription process.
Fantastic. Thank you. All right, so we want to spend a little bit of time now talking about quality improvement programs. So I'm going to share a little bit from the academia, community, and government collaboration that we developed during the pandemic and some of the lessons we learned. And we'll talk about that and speak also to a little bit more about some of the resources within the geriatric workforce enhancement programs. And Don will share with us some of the programs that he's been involved in with a quality improvement lens as well. So during the pandemic, we convened a task force at the center that I am fortunate to direct, and we've been working with the U.S. Deprescribing Research Network. And what we were finding, and we're continuing still to find, and that's why I feel that this theme is still very timely as we've looked at multiple waves of infection, and now we're worried about flu here locally and our staff burnout and shortage. But we really wanted to improve resident-centered health and well-being by reducing the use of unnecessary medications, simplifying the medication management approach, and then reducing opportunities for transmission for the COVID-19 for various viruses. So this really hinges on also stewardship and antimicrobial stewardship and infection prevention. So we really tried to tackle multiple approaches. So this work has been enduring through the pandemic, and we really took an interprofessional approach and put together a checklist as well as communication tools and resources. But I just wanted to highlight what we felt was very useful. We just finished analyzing some of our feedback on a survey that we distributed to over 2,500 participants who were willing to share their email with us. But we know from our website analytics, we had about 8,000 to 10,000 people view this tool that we put together. So from that feedback, the checklist, which is pretty customary as we look at quality improvement, is something people could resonate with. So this was a checklist we put together for the facility, for the pharmacist, for the teams. And this is very much in the public domain. I'll share the resources in my next slide, but we focused on what we said, the low-hanging fruit. Sometimes our older adults and others who reside in long-term care facilities are on multiple vitamins and herbals and other supplements. And we know those pills tend to be pretty big, and oftentimes dysphagia or difficulty swallowing a lot of pills at one time become an issue and they start coughing. And we're all very mindful of coughing and spread. So that was something that we looked at. And I know there's some pending work out there to be published and looking at reduction of over-the-counters and vitamins just by this initiative alone. We've also looked at ways in which to simplify and consolidate medication passes. So changing meds from 2 times a day to once daily formulations also helped, as long as you weren't crushing those formulations. And there's been some interesting studies previously from a quality lens and a cost effectiveness lens on the amount of savings of upward of $3 per resident per month that would be saved just on med pass time. And depending on the population which is in your facility, that can substantially save some funds. But it's also the burden on a very stretched and thinned out nursing staff who's struggling. So mindful of that. Looking at consolidation of bedtime meds with morning meds when you often have more staff than the evening time. And then reducing unnecessary monitoring, such as finger sticks or other blood glucose monitoring. And we tried to also be mindful of nebulizer treatments and switching to handheld inhalers if the formulation was effective and available. So these were just a couple of examples. In this section of the tool was something that people found very helpful. So again, why I share this is it takes a village to substantiate change, and by having these powerful partnerships that we've created through the years. And so all of these resources are available on the Lamy Center website, and this has really been afforded to our partnership of the US Deprescribing Research Network. And if you're not familiar with the US Deprescribing Research Network, I'm just going to do a little bit of a plug for you all. We have free webinars that are out there that are available. If you sign up for the network, it will push out alerts to you regarding funding, as well as presentations of national meetings to attend, especially if some of you go to the American Geriatric Society. And recently we conducted a wonderful video with a local older adult from our community who shared her voice from here in West Baltimore as a caregiver and an older adult on deprescribing and the value of the importance of communication, which Don and I will talk a little bit more about in a couple of minutes. So again, all of this is readily available for you, and always willing to answer any questions or comments that you have. Don, I'm going to turn it over to you.
That's great, Nicole. And I was just wondering, I put into the chat box there, when you converted from to inhalers from nebulized treatments, what's your impression about using spacers for these older adults? Is that routinely prescribed or as needed?
Unfortunately, Don, it isn't routinely prescribed. And what we've learned, especially sometimes with national formulary changes, and we took a scrutinized approach, I know from talking with peers of mine, when they switched from things like Symbicort to only Advair and some of the dry powdered inhalers, you can't use spacers with. So not every inhaler is the same. And some inhalers have unique aspects where you need much more forced inspiratory, like you can breathe in, and some of our older adults can't do that because of some of their airway diseases. So it's really an individualized approach. And so we're not successful all the time with switching to handheld inhalers. I have become quite a fan of some of those things like Respimat. I don't want to promote any product, but some of the ones that are more aerosolized that are easy, that aren't the dry powder that can sometimes be an irritant and cause cough as well. So we could get on a fun conversation about the plethora of inhalers and the lack of interchange and acceptability between those, and then the use and underuse of spacers. So yeah, something near and dear to my heart. Yeah. Sure, thanks.
Yeah, no, I was just thinking of my clinical practice. When I see Euclideum, I all of a sudden start thinking about outer space and what other things. It just sounds like a rare metal to me. But in any event, I also want to point out that non-pharmacologic management of COPD involves a new study out of University of Michigan, which is called harmonica therapy. And basically by pursing your lips and playing the harmonica, that helps improve your lung capacity. And I prescribed a harmonica to one of my patients the other day, and he just about fell out of his chair laughing. So it's a good thing to interact with your patients. Well, so we want to turn to some other examples. Now, we did a literature search, and Nicole, it's wonderful that you've got your program going. The literature search really didn't produce a whole lot of long-term care interventions for deprescribing, believe it or not. So this is one of them that I pulled up, and it was called the SMART campaign, which was an academically driven effort in collaboration or sponsored by the Indiana State Department of Health. It was a pilot program, and we don't quite honestly have a whole lot of information because they just it was more of a feasibility study, which showed that they could do this with the goals of reducing the number of medications, reducing the antipsychotics, anxiolytics, and hypnotics, and then overall reducing healthcare, prescription costs, for in long-term care. And obviously, a state that has public aid would have an invested interest in this because the large percentage of their costs in long-term care go to medication. So as you all may know, that when people come back from the hospital on vancomycin, that basically eats up the entire Medicare, if they're dual eligible, that eats up their entire cost for care. Okay, next slide, please. So I just wanted to point out that the SMART is an acronym for QAPI. And so if you're working in long-term care, the quality assessment and project improvement is associated with this paradigm of SMART, where you want to set goals that are specific. So for example, in working with your long-term care QAPI group, you want to specifically reduce, let's say, antipsychotic use. And so one of the projects may be something to the effect that when older adults with memory impairment in the nursing home setting are evaluated, that they be evaluated for pain, and then perhaps empirically treated for pain, as recommended by one study out of the British Medical Society, as a empiric treatment for pain prior to prescribing antipsychotics. So that would be a measurable outcome, in terms of the incidences of agitation. It's very achievable because you can work with your primary care provider and say, hey, next time you get that phone call about somebody that's agitated, maybe let's try Tylenol before we try the antipsychotic. So it's obviously very relevant to the reduction of medications. And it should be time-based, so you should be able to measure these within a very short period of time. Next slide, please. So the SMART campaign, getting back to the Indiana campaign, like I say, it was a coalition of different organizations, and that's the operative word here, is that when you formulate these relationships, that they be done so at various levels, cultivating the academic components, so that you can get some additional evidence-based medicine inserted into the project. It's important for provider collaborations. And so the medical director should play a large role in this, in discussing with other physician or provider collaborations, including nurse practitioners, and that there be an interprofessional team that includes the providers, the pharmacists, and that they be regularly scheduled meeting, and that they be driven by quality improvement. And the next slide, please. So we want to talk a little bit about communication and tools. Next slide. So some of the issues that come up with interdisciplinary teams are burnout, for example, and we're seeing a lot of that. Everybody says, oh, we just don't have the bandwidth to do age-friendly. And then I kind of go back and say, well, it's within your bandwidth because all of these things are already being done. And so when you ask somebody what matters, do you really want to go to the hospital? And so, from long-term care, that's an important question, as to what the survival rate is for that individual. What is their prognosis? And so you can go, as a very practical recommendation, you can go to e-prognosis. If you Google it, it'll take you to a website that will give you all these different conditions. But if somebody's frail, and well, not only all their conditions, but what their prognosis is, or life expectancy. So for example, if somebody has systolic heart failure, that they're in stage 4, you're talking about less than 6 months life expectancy. So there are things like that need to be discussed that often are not. People get frustrated. They don't want to handle end of life issues, either in the home or long-term care setting. And so by doing some preemptive discussion, you might be able to better prepare the family and the resident for alternatives that just maybe make more sense. The other issue that comes in terms of interdisciplinary team quality improvement is just the leadership support. It was interesting because in one of our projects that we had with long-term care, we got a lot more engagement when we reimbursed the nursing home for their involvement, as opposed to facilities that were not getting reimbursed. And so I think a lot of it has to do with resources and getting leadership to really support individuals for that. Now, mind you, my experience as a medical director in long-term care is that I always initiated QAPI, but I never got the bug from the nursing home. And they didn't say, oh, this is in your contract. And I really think that long-term care facilities need to remind their medical directors that that's part of their contract. That's a whole discussion about how you get medical director engagement. But I think that's kind of a 50-50 thing. You get half the medical directors that are involved and the other half that just kind of, slips on by them. The other part is person-centered care. And so, a lot of times we end up, so we did a survey in our nursing home consortium here in North Dakota, and we found out that over 60% of the residents screened by a specific tool for loneliness and isolation revealed that 2/3 of the residents express some level of loneliness and depressed mood because of the isolation. And so, your immediate reaction was that, well, with that information passed down to the providers, guess what? They're going to prescribe SSRIs. And one of my pet peeves here in the Dakotas is that the number of people that are on 3 SSRIs just blows me out of the water. And so I'm on a personal campaign to get it down to 2. And if the next step we can get down to 1 SSRI, I'm going to be one happy geriatrician. The other point is that as you set up your quality improvement interdisciplinary team meetings, that you have regularly scheduled meetings. So I would always meet with the PharmD from our long-term care facility on a monthly basis. It was structured. I said, bring your sheets for your recommendations, and we'll talk about them and get those changes made. So we kind of got 2 birds with 1 stone. Okay, so let's go to the next slide, please. Yeah, so I think the communication is really important. You got to keep these 3 levels involved. And it's a steady process. Okay, so you might say that you're going to either deprescribe or de-escalate a medication, and you just start the conversation. Don't give up the ship. Just if they say no, I don't know about that, or I want to think about it, you put that in your note and you say we'll come back and discuss those issues. And again, getting the family involved, particularly with the cognitively impaired patients, is really important. The best question is, do you think this medication is working? And if you get, I don't know, whoa, that's a good opportunity right there. Next slide, please. So I think part of this is whether it comes from a pharmacist or it comes from a provider or a nurse, any team member, quite honestly, is you want to introduce the concept of deprescribing. And this is the second point here is really so important, is that our bodies change over time. And boy, did I have an illustrative case here last week in my clinic. There was more than 10% body weight loss. The individual had sarcopenia, failure to thrive syndrome. And I just said, my gosh, it's like the 2-for-1 rule, right? I always talk about my father-in-law who used to have 2 martinis every night until he started to dwindle and get, from his Parkinson's disease. And we said, Dad, that those 2 martinis are actually 4, the 2-for-1 rule. So you really need to get down to 1 and only half of that maybe. So in his brilliance, he decided to switch his vodka for his martinis from a red cap to a blue cap, which went from basically 80 proof to 150 proof. So he got his 2 martinis into 1 glass, as clever as he was. But the point being is that for a variety of reasons, low albumin and other metrics, frailty and so forth, it may be time to trim the sails, and that's the point of conversation. And then trying to make a linkage between the current health and what their problems are, and then again, just getting that trust is just so important. Next slide, please. So these are just some of the practical issues that we can use. I kind of want to speed it up here a little bit because I see we're kind of 2/3 of the way through our slide deck, so I want to make sure we cover everything. So maybe the next slide here with the patient story, I can hand off to you, Nicole.
Sure. Thanks, Don. That was great. And just to add to the communication aspect, I know sometimes we're not always working in the same space at the same time, but Don, you hit on something, is setting up that time to meet one-on-one, whether it's virtually, whether it's in person, to really overcome some of those barriers of communication and trust, not just with your families and the residents and your staff, but amongst the providers. So I think those face-to-face opportunities are really critical. And I want to just go back and thank Dr. Green, whose research is really forward how to frame it up from a person-centered approach on terms to deprescribing. So, and I think we need to continuously be mindful of the way we approach different patient and resident populations. So let me bring this story because I think it really illustrates some of the sensitivities and challenges with navigating sometimes as a newer provider on a team. So this was someone that we saw in our practice. A 72-year-old man was evaluated by our geriatrics team. He had been hospitalized 2 months prior with a urinary tract infection. He developed delirium. He was discharged to a nursing facility for rehab. He was there under 100 days because of the Medicare Part A stay, and his children moved closer so they could provide support to the wife who was really struggling with maintaining him at home. When we started seeing him, we had these past medical history of chronic pain, hypertension, anxiety, depression, and dyslipidemia. Fortunately, Don, we did not have 3 SSRIs. I'm having palpitations here, and my QTC might be prolonged when I think about all those SSRIs on board, in all seriousness. But we didn't have to manage that, but you'll see the medication list in just a moment. What we did have to navigate, though, was some of the language barriers, because the patient we were caring for was originally from Vietnam. He had been a veteran of the Vietnam War, and he primarily spoke Vietnamese. His son was a pharmacist and a huge advocate, as well as his daughter being a teacher. They denied any alcohol or illicit substance use, but he was a pretty avid smoker up until about 5 years ago, when he stopped smoking on his own. He did not like to take medications. This is not his actual luggage here, but it just depicts some of the polypharmacy we see within our practice. I love this picture because a gentleman seriously came on his first visit with his luggage tolling behind him of all of his prescription and over-the-counter medications. This wasn't the gentleman because, quite frankly, he wasn't taking anything consistently. His son said he wasn't taking medications. He didn't like to take medications. And so he was really resistant. So prior to going into the hospital where he had this urinary tract infection, he was maybe taking his amlodipine sporadically, was the only thing we saw in his remote refill history. But as we kind of articulated earlier, as they transitioned through different care settings, he was layered on more and more medications, things for his chronic pain, his neuropathy, his blood pressure, his cholesterol, his mood, his anxiety, his delirium and agitation, his enlarged prostate, which was the underlying cause for his urinary tract infection because of urinary retention. And he was on a constellation of other opioids before, but his son, who was very adamant about the exposure and the use, with his father, who was already confused and at full risk, had discontinued them. So this was right before the pandemic started. I could share the story, but we don't have as much time as the pandemic evolved. But as I give you this snapshot, and as we want to engage all of you, where would you start in terms of deprescribing his medications based on this very limited information and based on your experiences? So chat in your rationale. We want to take a moment or two. We have you until 2:30. Hopefully you can stay with us until 2:30. But please chat in your responses. We'd love to hear that.
Yeah, I was going to mention, Nicole, while people are thinking of the answer, that 2:30 Eastern Standard Time, 1:30 Central Standard Time, and for those that are in Mountain Standard Time, it's an hour difference there again.
Thank you.
Yeah. So yeah, just put in the chat box, if you don't mind, your best thought as to what medication you would deprescribe for that case presentation. Great.
So some great thoughts. We have antipsychotics obviously being the focus, and second leader up would be lorazepam. A question being, have there been any trials for gradual dose reductions? No, Daniel, we hadn't done any GDRs really yet, but if you go back, I'll just go back for a moment to the preceding slide, you can see that there's some differences in the doses being used. So anyways, looking at these doses, not that there, and this is why we have this conversation. So our team decided to discontinue the lorazepam first because of his fall risk and because it was already a pretty low dose and the son was on board with stopping that one. There was a little hesitancy from the family's perspective to stop the quetiapine because he was getting agitated with the wife, and sometimes, I neglected to tell you, a little bit verbally aggressive with her. So the family felt he was a little calmer, and I'm going to put that in air quotes because that's a really very subjective symptom improvement. But again, when we look at person-centered care, so we as a team started with the lorazepam, but I completely agree we could have gone to the quetiapine route as well. Don, what are your thoughts with this case?
Well, this reminds me of my first ever case on call as a geriatric fellow. So this older gentleman showed up in the Duke emergency room, and thank goodness the emergency room actually called up the geriatrics program and said, we have this fellow who's agitated. What do you think is going on? And after we reviewed his medication, we found out that his wife had departed to visit family in California. Of course, we were in North Carolina. And so she kind of left him on his own to fend for himself. And two things had occurred in the process. One, she hid the vodka bottle. And secondly, she didn't lay out his pills. And so he had a little bit of memory loss, and he forgot to take his lorazepam. And so he had, withdrawal. And so I was going to actually ask you about that, both because of the benzodiazepine de-escalation, as well as the antipsychotic. What are your general rules of thumb for weaning versus just stopping cold turkey?
Well, as we both know, there's both that physical dependence that can happen with prolonged use, as well as the psychological dependence. And I think when we're using, whether it's alcohol, opioids, benzodiazepines, you need to meet the patient where they're at. I mean, there's been numerous publications looking at various tapers, depending how long patients have been on any of those agents. We're often very conservative, 0.5 milligrams. And as I think Trisha typed in the chat box, looking at the frequency of use of the lorazepam. Fortunately, it wasn't being used as frequently because he didn't like to take medication, so it made it very easy to discontinue, unlike the quetiapine, which the family was putting in the applesauce and giving it to him more consistently. So a lot of claims data may show you that, Trisha, but it may not. But getting to your point, Don, so I would have to say sometimes we reduce by 10%, sometimes 25%. I'm very conservative. Our geriatrician sometimes is a little bit more more aggressive. But I've had too many exposures as a practicing pharmacist for over 20 years to rapid because of both of those dependencies. And so, and what I've also found is being very explicit with a calendar with families, and also giving them what I call it is a helpline. Who do they reach if they start to see reemergence of symptoms, and what do they do? So I think those are just some of my pearls of success with deprescribing, but there are numerous tapering schedules out there, but we don't always follow them rigidly because our families and our patients may not always be amenable to that.
Yeah, I think those are excellent points.
Mm-hmm.
I always find that, giving the family, like you say, written instructions that, if after 2 weeks with this reduction, then not saying you have permission, but then either de-escalate to another dose or discontinue is really important. So they can see that. And then, just again, self-management is so important in this process, both in terms of self-management of escalating things like diuretics, but also self-management of de-escalating, medications. One of my, current efforts is to try to, for osteoarthritis, to try to replace opioids with turmeric therapy. Mm-hmm. So there is some emerging evidence that osteoarthritis can be treated, particularly of the knees, can be treated with relatively high doses of turmeric, of 1,000 milligrams twice a day is one example. And I'm finding some pretty good success. People are getting rid of that PRN tramadol as a result of that. So I think there's some additional strategies where you replace medications, drugs with natural compounds, and that sometimes is an appeal to the older adult.
Yeah, the only problem I find, I'd love to hear your preparation preferences, but sometimes the turmeric can get expensive. I've heard that.
Oh, yeah.
Yeah. So I know cost can sometimes be a barrier because it's not covered by their insurance, but really good perspective.
I tell them to go to the local natural grocer and grind their own. Here in North Dakota, that sounds pretty good to them because a lot of folks come from farm backgrounds. And I'm actually also surprised the number of people that had already initiated turmeric therapy. So they're already on board. It's just that they're not taking enough. And so just a lot of times I tell folks, I said, well, turmeric is an approved therapy for inflammatory bowel disease, but you have to take enough of it. It's 3 grams daily to be effective in inflammatory bowel disease. So, not that there's been a lot of studies, but certainly one would imagine if you're trying to have an anti-inflammatory effect, that you have to be in that 2 to 3 gram daily dose because not much of it gets absorbed. But yeah, those are all good points. Cost, it's really becoming more expensive, but the trade-off from that, the cost of that versus the cost of pain pills and constipation, and I had another person that was obstipated, which a lot of people don't understand in terms of nursing staff, is that obstipation induced by medications or constipation can be a source of mental status changes. Mm-hmm. In fact, some studies suggest that 40% of all delirium is caused by, locked bowels in the vernacular. So.
I'm not going to disagree to that. That's very painful and very distressful on a lot of facets. So Don, thank you for sharing that. And I think a really good perspective to the story of the importance of sometimes the regional differences, the cultural differences, and the self-treatment that sometimes our patients don't always share with us. So that's a really, really important point. I'm going to let you bring open case study number 2 to just keep us moving along so we make sure we have some great discussion for Q&A as well.
Great. So this relates to QAPI, which we should all be familiar with in the long-term care setting. So the Apex Rehab Center conducted a Plan, Do, Study, Act cycle for the QAPI on resident safety was their topic. And so they did a root cause analysis for unsafe medications, and they found out that 18.7% of the residents were prescribed antipsychotics, and this was relative to the national average of 13%. So the QAPI team launched a program improvement to deprescribe antipsychotics. Okay, so the next slide, please. So what additional information would you want in the root cause analysis? So if you can put into the chat box some ideas that you might have that might be contributing to the antipsychotic use, just please put those in. And so we had one hint earlier that the pandemic was causing more delirium, and so people were coming from the hospital with more antipsychotics. But maybe put in some thoughts if you do have any. We'll give you just a minute to put in the chat box your ideas. Yeah, thank you, Trish. Lack of non-drug interventions. Well, that's excellent point. So non-pharmacologic interventions is always first and foremost on everybody's thinking. So I think that's good. Jordan mentions about staffing crisis is impacting to form robust care plans. Yeah, I think that's absolutely true. And a lot of that I think is based upon what I want to call the lack of routinization or incorporation of QAPI into the everyday experience. And so what we find is that the high-end performers have been doing QAPI on a monthly basis, but a lot of the facilities are doing QAPI on a quarterly basis, or and so it ranges from doing QAPI weekly to monthly to quarterly to twice a year. So I think you're absolutely right, Jordan, and I'd be interested in learning a little bit more about which of those facilities are struggling with QAPI, because it should be part of their routine programming, and it's like practice makes perfect. And we found that with our long-term care, participants in our program, that even just doing a root cause analysis was a little bit of a struggle with them, because they had not really done that frequently. So again, I think that's part of it. So maybe if we could have the next slide just to show. Thank you for the input for everybody. Thanks, Rick. Yeah, activities are limited too. So here's a fishbone analysis. So this, folks may be familiar with this. So the different components of what can cause delirium or agitation. So in the environment, things to consider are the proper night lights as the environment. Have orientation cues like a large clock or calendar. What about noise levels? I mean, this is one of my favorites, because that overhead announcement. It's like somebody shouts out, "Who's got the narcotic keys?" And everybody jumps up out of bed like, "Oh my God, what just happened? Am I having a nightmare or what?" In terms of methods and processes, in the lower left-hand corner there is what Tricia had mentioned, no non-pharmacologic protocol. So how do staff CNAs actually approach the question of agitation? Do they redirect? Do they use food as a distractor? Do they have a pain management protocol, such as empiric use of Tylenol, and to use enough of the Tylenol to address any undetected pain? So then the other parts of this, I think, are fairly straightforward. Staff are not trained properly, or they've failed to implement these non-pharmacologic measures. And the other point, final point about people, are the overprescription of antipsychotics from the hospital and from other sources. Good. So let's have the next slide, please. And so what would you propose as an intervention to reduce antipsychotic use? So if you have any thoughts about that, please put that in the chat box, and we can use that as a point of discussion. So for those who are familiar with the process of active learning, when we ask participants to put their thoughts into the chat box, that's part of the active learning process. That it turns out that people learn twice as much from active learning than they do from the passive, watching the slides there. So yeah, so thanks, Rick, about the acetaminophen intervention. Yeah, the part of the, that's empiric, and that's been one of the recommendations for addressing pain management, making the older adult comfortable with agitation. One of the things that folks may not fully appreciate is, how do you measure whether the impact on antipsychotic use makes any difference or not. And one way to do that is to use the what's called a tool called the neuropsych inventory test. So that's a list. It's just a checklist that the staff can use, and you can do a pre and a post QAPI, plan, do, study, act cycle intervention to see if you've moved the needle on the MPI, the neuropsych inventory. Yeah, Betty is talking about engagement and activities and distractions. So yeah, you want to go to the literature and find all the non-pharmacologic, management. Yeah, one of my interests has been the use of live harpsichord music as a sedative, which apparently is very tranquil. It's the only instrument that's been demonstrated to reduce what we call heart rate variability as a physiologic measure. And nobody seems to understand why that particular instrument does that. So here locally, I've been trying to entice a harpsichordist here from the University of North Dakota music department to work with us on a long-term care intervention. So Avra talks about transitions of cares to evaluate those. Yeah, absolutely. So that's a point. And again, talking to the family, do you think this medication is making any difference? And so engaging, the transfer of care with the family member is as critical as working with the older adult who's in the long-term care facility. Well, great. Those are wonderful ideas. Thank you so much. So maybe back to you, Nicole, if you want to summarize what we've got here.
Yeah, absolutely. And I just want to do a shout out, Don, to Jordan as well. Jordan had mentioned having facilities with high antipsychotic or psychotropic use get together in interdisciplinary team meetings, including the pharmacists with other providers if possible. So Jordan, you're spot on. We found that really that high touch of those communication tactics we talked about earlier really helped to reduce antipsychotic rate. And Don, I just want to make mention, one of our recent graduates who defended her dissertation actually looked at Casper data, which looked at the deficiency level back in 2018. I know it was pre-pandemic, but one of the areas they talked about where they got deficiencies was a lack of monitoring. And as you said, structuring a tool such as a neuropsychiatric inventory is helpful to look at sort of change in behaviors and to defend why you may not do a gradual dose reduction. And so I think monitoring is really critical. And we talked about that with the deprescribing process. So the take-home points, hopefully you've enjoyed this as much as we have doing this together, but deprescribing is just one of the many tools to help us optimize medications to, again, meet our older adults and their families and caregivers where they're at in terms of their goals of care. Just as we articulated today, it really takes these interprofessional opportunities and teamwork to convey and make sure that we're working together with our communication tactics. And pharmacists are really critical when we look at champions for medication optimizations to help us improve effective communication. And one of our goals today was to empower all of you as a team to work together. And I think some of you highlighted the tactics in which to do that. And so one of the hopeful tactics that's going to continue well beyond this webinar and this recording is this wonderful partnership. So I want to turn it over to Rick or Sarah to talk a little bit more, as well as Don, about the Dakota Geriatrics website and some of the work that you're doing.
Dr. Jurovich, I'll let you maybe wrap up kind of the work we do day to day.
Okay, yeah, good. And then I'll hand it off to Rick with the questions and answers here. So this label that you see is called the Dakota Geriatrics. It's our version of a federally funded program from HRSA that describes or has different opportunities for learning. I just want to bring to your attention, if you are involved with either self-learning or working with trainees, that we have an online curriculum, for example, that talks about the biology of aging. So that maybe that would be introduced to your trainees. So you have access to that by going through the Dakota Geriatrics website. And then we have a variety of resources. We have ECHO programs, very similar to what we're doing here today, that happen monthly as part of an ongoing series. And then we also have other seminars and symposia. And you can basically, if you go to the Dakota Geriatrics website, you can peruse all the different offerings. If you want to enroll in our social media program. We have a program called Age Friendly, where you get to learn some geriatric clinical pearls and so forth. So again, just a variety of opportunities for learning and to get a better appreciation of geriatrics. So thank you very much.